Hey, this is Jacob, one of your chiefs. We're going to go through right now some of the very essential things you need to know while you're on call for our bariatric patients. When you come here, you're going to realize that bariatric surgery is pretty sweet. It is something that we are very active in, and it's a very big portion of our practice. Surgeons over here on the west side. Bariatric patients are different. They're definitely not what you would find to be kind of the normal kind of protoplasm. A lot of these patients are young. They might look, quote, healthy, except for just the fact that they're huge, but they're not. They usually have a lot of comorbidities, and even if they don't have diagnosed comorbidities, they oftentimes will have things like obstructive sleep apnea or Pickwickian syndrome, and they're really easy to fall off the physiologic curve. And when they crash hard, and they are a nightmare to take care from a critical care standpoint. They can develop, decubitus ulcers very easily just because of their weight. There's just a lot of factors that once they kind of fall off that curve, they crash and burn. And so you really need to keep an eye on these patients. A lot of your nurses up on 7 Tower in the bariatric wing, they're very good at kind of keeping you on top of things. But ultimately, if you get a call from the nursing staff, you need to go see those patients more likely than not. Some things can be kind of chart checked and stuff and kind of reassured, but some of the real bad things, you need to go see these patients. And the long and hard, or I should say, the long and fast rule for all of these kinds of things is keep your seniors informed. They're going to be the ones that help keep you uh, in the straight and narrow and not get in trouble. And that's kind of the long and short, quick thing for this to start out with. Some general FYIs, when you start taking care of these patients, look over the bariatric order set. There's a lot of things that are buried in there. There's a lot of nice details that, like Dr. Miller's going to pip you on, well, why is XYZ in there? And ultimately, it's a real good practice to look at these order sets, to know what's in them. Get your senior to kind of talk you through them. There's a lot of things in our bariatric care that is automated. The nurses know a lot. The order sets are pretty foolproof, but your job as kind of the surgeon, as the physician, is to know what to be on the lookout for. And that's what we're going to talk about a little bit. So here's a couple things that really should tip you off. The first thing, tachycardia, which can be really nonspecific in a lot of things, but bariatric patients, oftentimes this might be the only really key that you have. Leukocytosis is another thing. If a patient has a drain that's in place, Dr. Miller is a pretty big proponent of having a drain in all of his bariatric stuff. Dr. Paget is very selective in DABs as well. So changing the character is something that's important. Worsening or increasing pain. Some or all of these things should get your kind of ears alerted, and you should be trying to investigate why this is going on. The real major things that you'll encounter that are kind of like the big moments, the big problems are initially PE. Our PE rate here is very, very low, but it is a significant comorbidity or issue in the perioperative period. Leak from one of the anastomoses and postoperative bleeding. So, how do you figure out what's going on? What's kind of the thing you can do? Well, the nurses oftentimes will call you. I mean, that's their job. So, on the phone, some simple things that you can start out with are what are their vital signs? What is their urine output? Sometimes the nurses, they're not maybe the brightest. They didn't, start out prepared. And sometimes, it's like, well, just give me a little bit of how stable do they look, X, Y, Z. And then your job is to chart check. Oftentimes, I'll start with what are their vital signs? What's their urine output been so far since surgery or over the past day? Maybe what are their starting labs? All those things can give you a lot of good information to start out with. It's also good to know what your patient's coming to the table with. Are they a patient that has significant heart disease? Do they have renal insufficiency, or are they actually like close to dialysis? And you'll do that sometimes. You'll have a patient that undergoes a Roux-en-Y, and maybe they were non-alcoholic steatohepatitis kind of picture. They might have already just kind of a poor coagulation cascade at baseline. So all those things are really important to kind of look up and to be aware of. Then go see your patient. That's another kind of just big thing. Keep your senior informed, and then ultimately you need to see and evaluate these patients. Are they mentating? Are they in shock? Are they tachycardic on exam? Was this just a faulty kind of meter read? Do they have a drain? Is the character different? Does it look like gastric contents? Does it look, frankly, bloody? Those are things that can give you a lot of information. Is there pain out of proportion to their exam? Some of these patients that might have a leak starting to spill out some of their enteric contents, it might start causing or developing some signs of peritonitis. Those are things to be aware of. As a surgeon, you're also a trauma surgeon as well. The main, you can never go wrong with starting at the ATLS kind of basics, A, B, C, D, E. Make sure that their airway's protected, breathing, circulation, kind of use that as a checkpoint as well for you as you're going through this. And again, never a wrong thing to keep your senior informed. Your new second years might think that this is a little bit overbearing at times, or your third and fourth years, but ultimately you are never wrong to notify your senior of something that's going on a patient. Their job is to help and to ultimately take care of these patients as well, and your job as well is the same, but keep them informed. So for a patient that maybe has developed a leak, immediate post-op leaks, sometimes their only really findings might be tachycardia. The study of choice to really diagnose this is an upper GI study. We use gastrographin because it doesn't cause a terrible kind of brick-laden problem in the abdomen. It's if there is a leak and gastrographin gets in the abdomen, it's not nearly as big a deal as barium. Your senior is going to be talking to staff, when all this is kind of taking place. And again, things that might tip it off. The drain might be a different character. They might develop tachycardia, pain out of proportion on exam. They might develop a leukocytosis. Ultimately, like I said, the study of choice is an upper GI. And ultimately, you're going to need to make sure that they are appropriately resuscitated before they go to the operating room. Bleeds can happen. This can be intraluminal or extraluminal, in the peritoneal cavity. So a drain might tip you off. They might have bright red blood per rectum. They might get hypotensive. And we're going to have a talk about tachycardia and whatnot and kind of the things about it. But hemoglobin can lag as you're going through this. So looking at the patient's heart rate trend, looking at their urine output, those can be signs that a person is bleeding, and you want to treat them appropriately. You want to serially watch their hemoglobins. You want to make sure that their IV access is appropriate. And ultimately, these patients might need closer monitoring, and obviously, they might need transfusions. And then the last major thing is PEs. They're at significant risk. These people are very big sometimes, and their ambulation is important. They need to be up and moving around. They might only develop tachycardia when they have these PEs. I've had a patient recently that wasn't a bariatric patient, but she had a cancer, and on post-op day 1, she just got significantly tachycardic all of a sudden. And that was the only really tip-off. And ultimately, we did a CT study, CT angiogram, which is the study of choice, and that diagnosed that she had bilateral PEs. So, you want to work these people up. They might have hypoxemia, get an EKG, maybe make sure that they're not dropping their hemoglobin. But ultimately, like I said, the study of choice for ruling out a PE is a CT angiogram of the chest. That's kind of a brief overview of some of the main things to be aware of for the bariatric patients. There'll be definitely more to come. Hope this is educational for you. Thanks so much for paying attention.